Good afternoon, and welcome to today's Side by Side with the Division of Mental Health, Developmental Disabilities, and Substance Use Services, Improving Our System Together monthly webinar. Before we get started, here are a few reminders about the webinar technology. Please make sure you're using a computer or smartphone connected to the internet and the audio function is on and the volume is turned up. Please be sure your microphone is muted for the duration of the call unless you are speaking or asking questions. Questions can be submitted anytime during the presentation using the Q&A feature located on your control panel. We will answer as many questions as time allows after the presentation. American Sign Language interpreters and closed captioning options are available for today's event. The American Sign Language interpreters for today are Danette Steelman Bridges and Susan King Lanier. For closed captioning options, select the closed caption feature located on your dashboard. To adjust your video layout and screen view, select the view feature located in the top right-hand corner of your screen and choose the view that works best for you. Today's agenda begins with MHSU IDD TBI system announcements and updates. Our focus today is the DMH DDSUS 2024-2029 Strategic Plan. Topics of discussion include an overview of the strategic plan and next steps. There will also be time for questions after the presentation. At this time, I'd like to turn it over to Kelly Crosby, Director of the Division of Mental Health, Developmental Disabilities, and Substance Use Services.
Thank you so much, Dina. Hello, everyone. This is Kelly Crosby, and as Dina said, I'm the Director of the Division of Mental Health, Developmental Disabilities, and Substance Use Services here in North Carolina. So thank you all for joining us today. Today, we have a bit of an elongated session. We might take the whole time, we might not, but we wanted to make sure we had enough time to go over our new strategic plan. We did publish our strategic plan about a month ago. It was kind of right before Helene. And we have been really focused with our friends and loved ones and colleagues in the West and the rest of the state and Helene recovery and response. So I'm going to give you an update on that today too, because that's very top of mind for us. I want to make sure folks are aware of the resources and supports we have. And I just want to acknowledge that we've not in any way forgotten the long recovery process for our friends in the West. So we'll talk about that a little bit, but today's focus is going to be our strategic plan. It's our 5-year strategic plan. We're going to talk about our new mission and vision. And I hope it's not a boring session for you. I hope this is a session that makes you feel full of hope. This is our plan that says, I'm almost celebrating 2 years now in this role. It's been 2 years to spend time with you all, to go all across the state, to meet with you, to meet with families, to meet with consumers, providers, LMEs, other colleagues in our system like DSS and local health departments, and just get a better understanding of some of the real pressures and issues in our system today. And with that information, we created our strategic plan. What are our goals for the people who are served by and work in the public mental health, substance use, IDD, and traumatic brain injury system? So this plan reflects that. It won't reflect everything because there's too much. But it is a foundational starting place where we set goals for each part of our service delivery system. I'm going to talk about those goals. I'm going to talk about programs we've already put in place to start making a difference, to start reaching those goals. And then I'll talk a bit about measures, the very public measures we're going to share with you to show us success in the system. It is a 5-year plan, so our goal is that we do use it and we're accountable for it, and we publish routinely progress. We want you to feel the progress too. We want you to see the progress. We want you to see the data. But a year from now, we want people to say, I actually feel a difference in this space. I feel a difference in this space. This has gotten better. And if it hasn't, we need to retool and figure out why it hasn't and what else we need to do differently. But really, really excited to lay out this plan for you today for our public mental health, substance use, IDD, and TBI system. First, I'm going to start with some system updates. Next slide, please. So as a reminder, In October, we took down most of our routine collaborative events, our advisory groups, if you will. We will resume those in November, starting with today's side-by-side. We did do side-by-side last month, but it was devoted to Helene resources. But we will resume our normal standing meetings and all of our budget advisory meetings. So we just pushed back some of the deadlines for our advisory group activities. These advisory groups are largely around spending and accountability for the $835 million the General Assembly invested in our system last year, and those will resume again this month. Next slide. Talking about Helene a little bit. Hopefully folks have seen our Weathering the Storm website. There are lots of websites out there, and we're not trying to create Department of Public Safety's website or FEMA's or even the department's website. Those are wonderful, important websites that give lots of very practical, helpful information for those in the West, but also across the state regarding resources for Helene recovery. Our Weathering the Storm site is very specific to our population and to our public system. So what you'll find are a variety of resources, largely mental and emotional resources for yourself, your loved one, first responders, caregivers. So there are a host of helpful either numbers, information, places you can go for assistance on this website. So there are some statewide specific resources on here. And then there are links to both VIA's local community resources and partners' local community resources. So please visit Weathering the Storm. This is updated quite frequently, and I'm excited to report that later in the week, we will be uploading a toolkit, a workbook, if you will, for individuals with intellectual and developmental disabilities who are working through the trauma caused by Helene. So we want to make sure that caregivers and families and individuals have some tools to help folks work with the trauma and the aftermath of Helene. Next slide, please. Want to remind folks that we announced, I believe it was 2 weeks ago, our partnership with Somethings. And thank you to Alliance for also being part of this partnership. Somethings is an app. It provides peer mentoring for adolescents. It is a free resource available statewide for any youth who's interested and would like some peer mentoring. We've already had incredible interest. Close to 400 teens in the past 2 weeks have reached out for peer mentoring and supports. So again, we want to make sure that during this really critical time that youth feel like they have a youth-centric space to reach out, in addition to our typical resources like 988 and like the Peer Warm Line. Next slide. November is an important month of remembrance for many communities, and so we wanted to take a moment to call some of those out. November is National Native American Heritage Month. Very important. North Carolina is the proud home of the largest population of Indigenous people east of the Mississippi. We have many local, state, and federally recognized tribes here. It is important to note that individuals, Indigenous Americans, have very unique mental health, substance use, IDD needs. And we need to make sure that we have culturally specific services to support their needs. We have active partnerships right now with the Eastern Band of Cherokee Indians, lots of culturally specific services and supports that they develop in ways that are meaningful to their community. We're very proud of those partnerships, and we look for opportunities for more partnerships with Indigenous peoples here in our state. Next slide. It's also National Family Caregivers Month. You've heard me talk about this a lot. This is really important to me. I'm a family caregiver. All my family are family caregivers. And so I know what it's like to have dear and close family members with serious persistent mental illness and substance use needs, as many of you do. And caregivers are amazing and do amazing things to help people in their recovery journey. So we celebrate National Family Caregivers Month. One of the announcements that you'll see coming out probably in a week or two are our mental health block grant awards this year. We set aside a specific funding pot for family caregiver organizations, because we know that recovery takes a village, takes a community, takes a family. Healthy, supported families really help individuals in the recovery process. So we're very excited to announce those family caregiver organization grants a little later this month. Next slide, please. Also, this month is the Great American Smokeout. Why do I bring this up? Because y'all, smoking is a very serious problem for our community. Individuals with mental health, substance use needs often have higher rates of tobacco use, and we don't always support treatment for individuals with mental health and substance use needs. So it is very, very important that we encourage folks in our community to use resources to stop using tobacco. We want all of us to have long, healthy lives. So the Great American Smokeout's very important to our community. So encourage people to use that, use those resources, use the tobacco hotline, the free tobacco hotline here in North Carolina, and to use whatever resources that are available. There's lots of resources here available in North Carolina to help people stop smoking. Next slide. November, in November, November 11th in particular, we also celebrate Veterans Day. I'm very, very, very proud of the work that we do here and the partnerships we have with veterans in North Carolina. As you know, we have almost 1 million veterans and their families here in North Carolina. We also have active military here in North Carolina. And it's very important that we're supporting that community and supporting their mental health, emotional, substance use, IDD, and TBI needs. We have many proud partnerships with veterans. You'll see on this slide a list of some of them, like NC Serves, NC for Vets, the PATH program in the West, which is particularly important now as people are rebuilding from Helene. But we're very proud of our partnerships with veterans. Again, as you know, my dad is a veteran and has serious chronic untreated post-traumatic stress disorder. It's incredibly important that we find ways to connect with veterans and their families. So we're meeting the very unique mental health needs of those communities. Next slide. All right, now we're going to get into our strategic plan. All right, next slide, please. As the first part of our strategic plan, redid our mission and vision. The mission is what an organization is. And this was interesting because we had a hard time using plain language to describe what our mission was. It can be hard to describe what you do in a government program to the average citizen, but we want to make sure our community knows what we do. So here's the mission that we came up with. Here's our mission. We build systems, services, and supports that improve the well-being of all North Carolinians with a focus on mental health, intellectual and developmental disabilities, substance use, and traumatic brain injury. So again, trying to distill down, we build systems, services, and supports. We get dollars and we work with local communities to build systems, create policies and programs that improve our public mental health, substance use, IDD, TBI system. But here's why. So that's what we do. Here's our vision. We think this is the right vision for North Carolina. We envision communities where all are supported to live healthier and happier lives. That's the ultimate vision. That's why we want to do everything that we do. And you'll see across the board with whatever priority area and goal we're talking about, it's because we want people to live their fullest, best life. That's not a cliche. That's what our service delivery systems should be doing. It should be focusing on inclusion, community integration, recovery, resilience. People should be able to live their best life, and our services and supports should help people to do that. We also have principles. These are really important to us, and you will see throughout the strategic plan, if you've read it, and through the way we think through how we present data to you and how we fund specific things, that we're focusing on our principles. One of our principles is honoring people with lived experience. People with lived experience should drive what we do. They're the people in the system receiving the services, or their loved one or colleague or friend is receiving the services. They know what's working and not. They know what they need and not, and we need to honor that and listen to that and lift up the lived experience as much as possible. We need to have equity. So everyone deserves to live a healthy life in their community. And we need access in all communities, and we need it to be a culturally appropriate access. So we need to make sure that, in particular, marginalized communities are getting equitable and culturally appropriate access to our services. Inclusivity. Our services have to be inclusive. We all receive services in different ways. We all need services and supports in different ways, depending on our age, our gender, our religious faith or belief. That all matters, the culture that we come from. And so we need to make sure that we're mindful in building a service that meets the unique needs of everyone and that we're inclusive as we can be. We also want a quality system, right? We got some wonderful funding from the General Assembly. We don't get that all the time, but we do get some money from state appropriations and from the federal government. We need to use the bit of money we get to the best of our abilities, and we need to be paying for the highest quality services we can. It's not about quantity, it is about quality. The dollars that we have, the services and supports that are provided should improve the quality of people's lives, and we have to be able to measure that. You'll see in early plan measurement, we focus a lot on widgets, how much was provided, how many people were provided. And that's the right place to start, just so we understand the landscape. But we need to, sooner rather than later, move to quality measurement. And lastly, trauma informed. We know that a lot of folks in our system are often mislabeled or tagged as being the problem, if you will, rather than recognizing that many of us, right? And I say us because this is all of us. We have grown up in or lived in a system or situation or a family or a community where we experienced trauma. And a lot of the people in our system now who are maybe only 15 in our system, but who could be 40 or 50 in our system, have been experienced trauma, not just in their communities or families, but also within the service delivery system itself. And we need to be focused on a better trauma-informed system that is focused on healing, recognizing that people deal with trauma, not labeling them as problems, and making sure when they do find our system, that it's high quality and therapeutic and doesn't lead to re-traumatization of the person. Okay, next slide. Let's talk about the actual priority areas. Oh, the strategic plan development process too. Next slide. Thank you, Jay. So I hope folks remember, we've been working on this probably for 6 months now, right? Probably a little bit longer, 6 to 9 months. We spent a lot of time having listening sessions, meeting with folks, presenting drafts in meetings, because we really wanted to get this right. Check the temperature. Are we hitting on the right elements? Are we hitting on the right goals? Are we hitting on the right measures? And this is where we've landed. Next slide. So let's talk about our strategic priorities. I'm going to go through each of these. And as a reminder, I'm going to run through the priority area. I'm going to talk about the initiatives, so the programs we are planning on focusing on to get us to goal, and then some ways we've already enacted some of those things. So I'm going to tell you about programs that are already happening, so you know about them, and then some measures, okay? And the reason that I tell you about these things, and this is really, really important, there'll never be enough money, there'll never be enough time and energy, right? And one of the things we suffer from sometimes in a public system or a nonprofit system is having to chase the most recent funding source or the new idea. That will always happen. That's never going to go away. But with this plan, we're trying to say, like, consistently, we think these are the priorities, and we actually think these are the programs we want to work on. And for us, that means a commitment. That means a commitment to telling you this is what we're going to put our block grant dollars towards. This is what we'll work with LMEs on. This is what we'll work with the Medicaid team on. So that's our commitment to you, right? I want to give you some stability and say these are the programs we think will lead towards some of the outcomes that we're looking for. So here are our priority areas: increasing access to care across the state, improving access to quality IDD and TBI services, preventing substance misuse and overdose, building the workforce, strengthening the crisis system, expanding services for individuals in the justice system, and amplifying recovery and community-based services. I'll unpack that one a little bit for you if you don't quite get what that means. But now I'm going to walk through each of the priority areas for you. And you can see my background. The background has all 7 priority areas on it, and they're color coded and they have a little icon. So we're trying to make this as accessible as possible. Okay, let's go to the next slide, please. All right, coming soon. I'm going to give you a little taste of measures right now. And we do actually have a draft strategic plan dashboard where we look at every measure and we show our progress across that measure. I'm going to show you for each area. I'm going to show you what the measures are, and I'm going to actually show you one dashboard slide for each measure. But this will be released actually later this month. We didn't want to hold the webinar any longer, but it needs a little bit of fine tuning, but it will be released very soon. We will update it quarterly. And we're going to review some select charts today, as I mentioned. Okay, next slide. So let's talk about the first one. I love this one. You hear me talk about this one all the time. Priority 1 is increasing access to care across the state. For us, that means increasing treatment initiation and retention, meaning it needs to be easier for people to begin treatment. We need to do things to make sure people stay in treatment because we actually think treatment works. But a lot of people raise their hand and never make it to treatment. So there are things in the system, things in the community, things in society that are keeping folks from initiating and engaging in treatment. We also want to promote access to integrated care. So whatever that is, can you get mental health care in your primary care doc? Or if you're in your substance use provider's office, are you also getting physical health care as well? So we're going to talk about that a little bit more. And then we want to increase access to caregiver support. So more people starting in treatment, staying in treatment, more people getting whole person treatment, right? Not just one of their needs met, but all of their needs met. And then more support for caregivers. All right, next slide. So look at all the many interventions we're going to engage in. And I will actually show you some of these that are already in process. Okay. Accessible communications campaign. A primary reason that people don't access services is because they don't understand our service delivery system. It's that simple. And I find that both frustrating, but also manageable, right? If we know it's a problem, let's fix it. So we started earlier this year our accessible communications campaign. And I have a goal to make sure that people understand if they need services, where to find it. That's why we heavily advertise things like 988. I'd be hard pressed. You're hard pressed right now to go to a grocery store and not see a 988 sign. And I'm thankful for that, right? In the parking lot, you're going to find a 988 sign because we're trying to promote more easier access to mental health services. So accessible communication. Our care directory. We are working on a care directory. Again, when you come to our website, it's fine. It's being improved daily. But I want people to be able to find care when they need to find care. We'll unpack that a little bit, okay? It's a barrier, right? When you think about, I want treatment, okay, I'm gonna get it. I think I know to call this number, and then I go to this website and I have to find out which county I'm in and which LME I'm in and which 1-800 number. It's just too hard. And then there's names of services that are confusing. What's IOP? What's IIH? What's MST? What's level 3 group home? Very confusing. It doesn't need to be. But what's a really simple directory we can create for people so they see the easy entry points into the system? Unshamed North Carolina. Unshamed North Carolina is an anti-stigma opioid campaign that we are slowly starting. They've done it in Kentucky and California and seen amazing results in terms of changing public attitudes towards opioid use and the use of Medicaid for opioid use disorders, MOUD, and greater uptake of MOUD in those states. So we'll be doing that. We will also do a mental health stigma campaign. I was telling folks today, and now you're going to hear me repeat this, but I was telling folks today that, I've worked for DHHS for many years, 12 of those years with the state Medicaid agency. And as you know, Medicaid is a low-income public insurance program. And it was very easy for me to talk about growing up poor and needing public assistance, or my dad turned it down, but qualifying for public assistance. And that was publicly acceptable to talk about. But I realized that I didn't talk about, and it was not publicly acceptable to talk about, that I grew up in a home that had so much mental health and mental illness in it. That was not acceptable to talk about. And that's not okay. It's really not okay. We need to move beyond that stigma. It's 2024. We all manage our mental health every single day. And it's okay to talk about. So anti-stigma campaign, it's coming. We're also working with the LMEs on open access. So again, those walk-in clinics in communities where people can just go for an appointment without waiting. So how can we have more opportunities for open access when an adult or child needs treatment? In the integrated care space, we already fund about 8 certified community behavioral health clinics across the state. Those are comprehensive mental health and in some cases, substance use agencies that also provide care management and coordinate with primary care. Some even provide primary care. We fund those already, but next year we'll be launching an initiative to really emphasize CCBHCs as kind of safety net places for our community to go for a first appointment, for crisis service, for coordination with primary care. We get federal dollars from this. We get more federal dollars for it. And we're actually working with the Medicaid team on a prospective payment. So there is a whole person payment, which will actually help with funding this really unique model. So wait for that next year. We're also working with more models like NCPAL and collaborative care. Our announcement around collaborative care funding will go out today, but that's been a couple of years now, and that really is bringing psychiatric consultation and social work services to primary care offices. Medicaid pays for that. They pay a good rate. And there are grants now to help practices start this model up. Our mental health block grant. You'll notice that this year we're using our mental health block grant to increase inclusivity and reach communities we don't always reach. So we have grants for Latino communities. We have grants for LGBTQIA plus communities, faith-based communities, caregiver organizations. Because again, people engage with the system in many different ways, and we need to make sure that we're supporting that kind of entry into the system. So you'll see funding for that coming out very soon. We are also expanding our NAMI on campus because, again, we believe in peer-led models of care. NAMI on campus is really successful. We want to make sure that there are chapters in every part of the state. One of our stretch goals, this is a stretch goal, are our third space projects. We've had some interesting conversations with both the YMCA and the library system here in North Carolina, because we want to make mental health that accessible that they have rooms. They have telehealth rooms on campuses. Other states have done this, where folks can go to the YMCA, maybe go to a group at the YMCA, maybe use the telehealth room. Same thing at the local library. So create places where people go, not just to use the computer and the internet, but they can actually go for a telehealth visit. They can talk to their therapist via telehealth at one of these public spaces. We also, you may know, here in North Carolina, we're well known for our maternal health substance use programs, our perinatal and postpartum substance use programs. We want to be just as well known for our maternal mental health programs. So that's one of our stretch goals as well, to really up our game in terms of maternal mental health. So it's a lot. This is a big one, but the whole concept here is, how do we focus our energy on making the system more understandable, easier to access? How do we reach populations we haven't reached yet? That is our focus here. All right, next slide. I mentioned some of these already. So we've started the accessible communications campaign where we've explained things like what's a tailored plan, what's care management. Now we're doing 1959 services. I mentioned the network of care coming. It's going to be a really simple interface where if you need a first appointment, go here. If you want a family caregiver support group, you go here. If you need a crisis service, you go here. It's going to be that simplistic, y'all. That simplistic. No complicated directories, but how can you find care right away? And I mentioned the Anti-Stigma Unshame North Carolina campaign coming. Next slide. I mentioned the block grant already. As I mentioned, we released, hopefully folks saw the RFA. It is closed now. We'll be releasing our announcements, and we're trying to use the mental health block grant to reach communities that we're not always reaching. We need to be more inclusive, and we want to use our dollars to seed those opportunities across the state. Next slide. Strategic plan measure. So how are we going to measure how we're doing around access in our system? So the first thing is we're going to measure the number of individuals beginning mental health treatment. This goes back several years. And this is a person who went in for one visit and came back for a second. Do you see how we have been static for years and years and years and years and years? It's really been static, y'all. Yes, there are a couple spikes here or there, but by and large, we're not necessarily making a dent on people coming, making that first step, going to a first appointment, and having such a good experience and understanding enough and feeling comfortable enough that they want to come back for more. We need to change that. The second measure is individuals continuing mental health treatment. Individuals using collaborative care, that's that model of integrated care in a primary care setting. And then the number of individuals receiving care at our certified community behavioral health clinics. Those are our measures. All right, next slide. Let's talk about our next priority, increasing access to quality IDD and traumatic brain injury services. This one's pretty simple. We want to increase the number of people receiving services and supports for intellectual and developmental disabilities, for traumatic brain injury. And we definitely want to increase the number of people who are using community living supports and competitive integrated employment, because those are our services that really assist with community integration. Next slide. So here's our initiative, Inclusion Works. I hope you've heard me talk about Inclusion Works and Ginger talk about Inclusion Works. Ginger would be here today, but she's at the Hope North Carolina conference talking about Inclusion Works and Inclusion Connects. Inclusion Works is about helping people who are in vocational programs get into competitive integrated employment if they so choose, meaning they work in an integrated environment for an equal wage and have equal opportunities for career advancement. Why not? Everybody should. We should have an inclusive work environment, inclusive world. We'll also be launching IDD peers. I think the work group, our IDD advisory group, is already looking at curriculum for IDD peers. We've got mental health peers and substance use peers. We need IDD peers. Individual and family service direction. This is one of our stretch goals. We've had individual direction and family direction and employer of record for a very long time now, but we know that it needs to be revamped and revitalized. We want to have more people directing their own services in a system that actually makes sense, and services that make sense for people to direct their services. Today, we released our community living guide. It's our housing guide. I think that hot topic is going to come out any moment now. We've got a lot planned in the housing space for people with IDD. We're working, of course, with our Olmsted team and with our LMEs who all do regional housing plans. But some of the initiatives we're engaged right now are helping us assess both our housing needs and our housing stock. The housing plan that we just released talks about housing that's available, funding that's available, and services that are available for housing. So you'll see the website, you'll see those 3 different categories of resources. And part of that was helping us just to organize what it is. And boy, it's complicated. It's complicated what the housing resources are, what the service resources are, what the funding resources are. But at least we have it all in one place now in a guide for folks, and that's the beginning. One of the other things I'll talk about in a minute is helping us to capture the housing needs of our community. And we want to have a comprehensive housing vision, understanding what types of housing that we need, what kind of service and supports and funding that we need, so we can make smart asks to the General Assembly. You all know we have permission to expand the TBI waiver or to submit a waiver to CMS. We are working closely with the Medicaid team on expanding the TBI waiver. Tailored care management is a priority for the state, and in particular for our division, we've been working with the Accessible Communications Campaign just to make sure that people know what it is. We want more uptake of the service, we want it to be an effective service, and we want more people to get that care navigation that tailored care management can bring. One of our stretch goals is also to work on intimate partner violence in the IDD community. Overall, we need to do better to make sure that we're recognizing the emotional and mental health and substance use needs of our IDD community. We don't do that. We silo systems, so we want to work on that. And one area in particular we've been challenged to work on by our CFAC is the area of interpersonal violence. And so we will be working on that as a stretch goal. I mentioned Inclusion Works. Inclusion Connects is not just about getting people in employment. It's about getting people in housing. It's about getting people in services, and it's about working on the direct support professional workforce. So you'll see some of that in upcoming slides. We want to make sure that people just have access to services, home and community-based services, especially people on the wait list. And you will see in a moment what we're doing around waitlist monitoring and outreach. So again, a lot here in this space, but many of these things are in progress already. So the next slide will show you, if I'm not mistaken, Inclusion Connects. We launched Inclusion Connects back in March. It is a website, it has resources on it, and every month or so it gets updated to talk about new initiatives in this space. Again, it's focused on improving access to services, improving and getting more folks in the direct support professional workforce pipeline and retaining them, and then making sure that we have adequate housing and supports for people with intellectual and developmental disabilities. So the website is live. Next slide, please. Something that's coming in December 2nd, actually, is the Innovations Waitlist Dashboard. Wait for it, y'all. You'll be able to see a statewide view and also an LME specific view of who's on the wait list. So it has gender, race, age, diagnosis, county. So we have this now statewide and by LME. We're also looking at the data to be able to publish housing data and get a better sense of housing stock. So we're looking at all the data we have now on the waitlist dashboard. It will become public on December 2nd. And we will continue to add additional data elements to it. So it is just for public transparency, but it's also for planning purposes. One of the things you'll notice is the #1 diagnosis statewide for individuals on the wait list is autism. So what does that say to us? Got thousands of people with autism on the waiting list. Okay, what does that mean for what kind of services and support do we need to be building across the state, for example? Are there communities that are underrepresented on the wait list, right? Are there counties underrepresented on the wait list? Are there marginalized groups underrepresented on the wait list? And what do we need to do to address that? Next slide, please. Today, we launched the Accessible Housing Plan. I mentioned that before. That'll come out in Hot Topics. So it does help with how the housing resources, the funding, and the supports available. I mentioned the Olmsted Regional Housing Plan, so props to the Olmsted team and Josh for working on a regional housing plan, so we feed into that. And again, we'll be using the wait list. We'll be using feedback from the community to better build out both our housing needs and our housing plan, and in some cases, an ask to the General Assembly on what kind of housing we need to better support people with intellectual and developmental disabilities. Next slide, please. Inclusion Works. I mentioned Inclusion Works already, but this slide I wanted to show you that I want to show you some of the numbers. So right now, you may know this or not, but we've got 2,600 people receiving supported employment here in North Carolina. And you can see the counties. The darkest shade of county is where people are receiving supported employment services. We have about 1,400, almost 1,500 people who are receiving services in an adult day vocational program. So of those, almost 700 people have said, I would like to move from my ADVP towards a competitive integrated employment program. So how can I do that? So competitive integrated employment, the Inclusion Works initiative is all about helping individuals know their choices, get the services that they need to gain competitive integrated employment. It is aligned very well with DVR or EIPD. That's the new name for vocational rehabilitation. We're very aligned with all the employment providers in North Carolina. Awesome group of folks, awesome group of folks. There are grants for providers who want to revamp and change their programs. And there's also financial opportunities for those providers doing innovative things to train and coach other providers in the state. So it's a really cool activity that's been ongoing already. You just might not know about it. All right, next slide. So in this area, we're going to measure the number of people on the innovations waitlist who receive services. Pretty exciting, right? It's more than you thought, probably 45%. But here's what we know. And what you don't see reflected on here is part of what we're doing is not just looking at the data we do have, it's figuring out ways to get more data. How can we do active outreach to everyone on the wait list, ascertain their current needs, get them hooked into iOption services, and have a better accounting of services and supports people need so we can make smart asks to the General Assembly for everything like funding, more services, more state dollars, more slots. Okay, so that's one of our measures. We are also measuring the percent of, this is very specific, right? People who are on innovations, who have authorized services but aren't getting those. We are trying to measure and increase the number of services people who have an approved plan are actually getting. We know people aren't getting services in part because we can't keep direct support professionals, right? So a way to measure the strength of a workforce is measuring how many of those services people are actually getting. We also want to increase the number of individuals receiving traumatic brain injury services, whether it's on the waiver, which we know will be expanding, or state-funded TBI services. I feel like it's about $3 million a year for state-funded traumatic brain injury services. You should see what services people are getting, and we should make sure they're getting them. And again, we're also going to measure the number of people with intellectual and developmental disabilities receiving supported employment. So that's what we measure. Like I said, a lot of tick boxes, but those are important. Just the number of people in things that we will share with you. And we expect these to go in the right direction. Okay, next slide. So let's talk about priority area 3. Preventing substance misuse and overdose. Now, this one's pretty simple, right? When you think about goals, we want to make sure that more people are engaged in primary prevention. So do we have a robust statewide prevention approach, a local community prevention approach? And are we getting people into evidence-based substance use services? So let me unpack that a little bit with what interventions that we're going to be working on, what programs we'll be working on and funding. Next slide. So the first thing is expanding access to office-based opioid treatments and getting support from NCPOW. I've told this anecdote, this true story, to my colleagues at substance use conferences and in the substance use field. You'll see in a slide, we have a very robust network of OTP clinics, outpatient treatment providers. Clinics, some of you who aren't in the field may think of them as methadone clinics. That's not all they are, but that's what you may think of them like from history, right? Where people go to get treatment, to get induction, to get doses, to get a take-home dose, to get a guest dose. And those are wonderful. We have such a robust network in North Carolina, and they do amazing things. We're well known in North Carolina for that. But not everyone will go to that setting for treatment. So one of the settings that we're trying to make sure we have available to folks who are office-based, primary care docs can prescribe things. They might need support through things like NCPOW, which is a consultation program. And we need doctors to feel equipped and comfortable. And there are plenty of people. The story I share is that I've got a loved one, my uncle. He would have definitely gotten medication for opioid use disorder from a primary care doc, but he would never go to a clinic. He would never go into a clinic for medication. So we want to, again, it's about access. We want to create the spaces where people will feel comfortable, making sure all those spaces are equipped with treatment resources for people. We need to expand substance use disorder treatment for adolescents. Flat out, we just don't have enough, y'all. We do not have enough across communities to make sure that we're appropriately offering options for kids and their families. Before I get to prevention, every year we have something called a naloxone saturation plan, and we have a method for distributing it. We are required by the federal government to come up with a plan to say, here are problem spots, here are all the industries and the spaces we need to get naloxone, and here's how we're going to offer free naloxone to those spaces. Every year we updated it. We've updated it this year, but then we went to a conference and we'll update it more because we're always trying to make sure that that is the best that it can be. This year, we want to develop an MOUD saturation plan. So let me unpack that right quickly. MOUD, medications for opioid use disorder. I mentioned methadone, Suboxone. I mean, those aren't the only things, right? Medications work. Do you know in North Carolina that a lot of treatment providers or treatment spaces refuse to offer medication? They don't feel comfortable with it. It's not in their treatment modality. Here's what I say to that. First, individuals need to choose their own recovery path. It's non-negotiable. Choose your recovery path. 2, individuals should have choice. And so what's important to us is that we understand all the spaces and places where people will go for treatment. the spaces and places that either don't know how to offer medication for opioid use disorder or are uncomfortable doing it, or it doesn't fit with their treatment milieu, and help. And have a plan for making sure that people have choice when they go into treatment. That's all we want, choice. Again, recovery journeys will differ, but MOUD is actually quite beneficial and it's life-saving. We just want to make sure people have choice and we get down some of that resistance to MOUD. One of the ways we're expanding treatment access to is our mobile opioid treatment program. Yay! I'm going to show you a map in a minute to celebrate how many opioid treatment programs we have across the state. And we are so close to having a clinical coverage policy for OTPs. We got an emergency rule so we can have mobile clinics, and that expands reach in so many places for people who cannot get to a clinic for their medication. So very excited about that. We also want to stretch a little bit and expand our use of post-overdose recovery teams. So when someone does overdose, this is a team that might connect to the person, make sure they're connected to services, make sure they're okay. It's a big deal to overdose. It's a really big deal. It's a wonderful deal to survive, but those folks need services and supports and connection, okay? One of our stretch goals too is to focus on recovery communities and workplaces. So we've had the privilege of working with the Triangle Business Journal and talking with businesses as ways that businesses can help people in their mental health journey, but also their recovery journeys. So how can we help businesses, not just in the Triangle, but across North Carolina, raise their hand and say, I want to help. 1 in 6 people deal with substance use issues in our state. So how can we penetrate more places in our system? Collegiate harm reduction. You know, I hope you know, we've got many collegiate, it's not, I got harm reduction in my head now, but we've got many collegiate recovery communities across the state. We fund many of those. It's a safe space for students in recovery to maintain their recovery, go to sober events, get counseling and treatment and support from their peers, while still having a college experience, which can be really stressful and not conducive to recovery. We also want to make sure that those communities also focus on harm reduction, because we know that when people who are young adults, that's when use typically escalates and turns into a problem. So how can we teach, how can we help people in recovery, but how can we also help people to use responsibly if that's how they choose, right? Instead of escalating into a problem. So that young adult group, we're trying to reach adolescents and young adults. And then lastly, back to prevention. A lot of that was about treatment, making sure we're getting evidence-based treatment like MOUD through mobile clinics and in primary care clinics. And we have a saturation plan for all the places that are uncomfortable with medication. And we're expanding to like workplace supports and colleges and youth. Prevention though, treatment's great. We're good at it here, y'all. We're good at it here. We got a strong treatment recovery community in North Carolina. But prevention, we also have strong prevention. We're well known for prevention in North Carolina. You may not even know that. But we're looking at our prevention activities. How can we refresh them, give them a boost? We are looking at other models of prevention and healthy youth engagement from even other states, but also other countries, to see if there are new models that we can adopt and use here to have a revived prevention plan here in North Carolina. Next slide. I mentioned some of this. These are just stats. You'll get the slides. We help a lot of people, but there are 2 stats I really want you to look on here. In 2023, we treated 48,000 people with opioid use disorders. 2022, we treated 49,000. That number remains fairly static. So again, back to that access engagement, we need more spaces to engage people, and we need more access, and we need to reduce stigma. I'm proud of how many people are getting services here, but we need to increase that engagement. Next slide. Good news, y'all. This is me pointing out things that, since we're already working in these spaces and we've already initiated some of these engagement, this is huge. In 2023, we had 866 opioid overdose ED visits. In 2024, we had 510. That's a miracle, y'all. I credit our substance use community, but this is a huge indicator in our system that the preventative, the treatment, the overdose, follow-up, the naloxone kits, the education, the partnership across the state, the naloxone saturation plan, the harm reduction programs are making a difference. So well done, everyone. So a lot of those things that I mentioned are in play. We're just trying to spread them out with mobile clinics and primary care clinics, as I mentioned. Next slide. This is just a map of all the outpatient treatment programs we have. We have a lot. We have a live system that actually tracks which are open and who, so they're really nice. We also have more pending programs. So just a shout out, this is something that's happening now, increasing our opioid treatment program footprint. We have 19 people pending, and we're well known across the nation for making access to outpatient or opioid treatment programs available here in North Carolina. Next slide. So here are strategic plan measures. So again, we want to measure the number of people served by our opioid treatment programs and the office-based opioid treatment programs. We need more, y'all. There are plenty of people that are not being treated right now, and we remain static. So let's get more. We want more people served by our collegiate recovery programs and our recovery community centers, which we'll talk about in a minute. We really need more people in treatment, children, adolescents, and adults. And we need to decrease our opioid overdose emergency department visits, which are already going down. Look at this particular slide that we're showing you. This is the number of children and adults who have initiated substance use treatment. Again, pretty flat. So we need to do better, right? Medicaid expansion will help because more people have insurance coverage. They're not just relying on substance use or state funded treatment. So that should help a lot. But we need to make sure, again, that people are getting access to services that are meaningful to them without stigma and use evidence-based practices. Next slide, please. Building the workforce. So in building the workforce, we have 4 key areas that we're focused on. One is our peer workforce, and everybody knows, love peers, right? I think a strong peer workforce is very important. So we're focusing on peers. We need to strengthen our direct support professional workforce. Talk about that. Here's the last 2 we don't talk about much. We haven't kicked off many initiatives in these spaces, but you'll see them coming. We need more licensed professionals in the field, in the public system. I'm a licensed professional. Licensed professionals are uniquely well-trained and qualified to provide treatment and therapy to people. We need more coming into the public system. We just do. And we also need to have more supports and formal training and formal programs for all of our unlicensed professionals who actually make up the bulk of our workforce. So qualified professionals, associate professionals. That isn't a thing. A QP isn't a thing. It's a particular designation we have here in North Carolina, but people don't go to school to be a QP. So how do we make sure that we are helping people come out of school, associate's degree, bachelor's degree, prepared to come into jobs in our service delivery system? All right, next slide is initiatives. Some of these we're already working on. We've been working a lot this year with you all in our advisory committee on revamping the Certified Peer Support Specialist program. We also published a direct support professional workforce plan, and we're actually working on the initiatives in it. I'll show you some slides. I mentioned we're really leaning into working with the community college system to get people into the pipeline. What are associate's degree they can get at a community college, or even bachelor's degree that prepare them to come ready to work in our system, right? So coming out with a degree in psychology, I had a bachelor's in psychology. I don't know that it prepared me to work in the system at all. So how can we work on that? How can we have degrees that make sense to help people move into the system? We need clear oversight and infrastructure of our crisis system. So won't unpack that one today, but we'll talk about crisis in a moment. And part of what we need to do is make sure that we have well-trained crisis staff across the continuum. We also need, as I mentioned, more licensed professionals coming into the system. So we have some burgeoning partnerships like with the UNC system and the license consortiums across the state that we're very excited about to try to entice more licensed people to come into the field. And for us as an agency, I don't know if you know how very much training and CEUs that we provide here across the division. So we want to do a lot to actually streamline that, make it more meaningful and helpful to you in the community, and for us to get the ROI that we're looking for. If we're going to sponsor evidence-based treatments or even sponsor practicums or scholarships at schools, it's good, and we will continue to do that. We just want to make sure that's funneled back into our public system in meaningful ways. So let me tell you about a couple things we're already working on the next slide. So we already published our direct support professional workforce plan. It focuses on retention, recruitment, standardized and helpful training. We got lots of feedback from the community, and we're actually doing some things now. So if you go to the next slide, I'll tell you what we're actually already working on. So we released our provider agency recruitment and retention grants. Okay. We just full transparency. If you're on the advisory committee, you know this. We were going to fund a recruitment and retention program. We heard loud and clear from providers that they need the flexibility to try different things out. So the grants became very broad. Agencies are allowed to get a grant to try recruitment and retention grants within their agency. And it could be things for hiring bonuses, retention bonuses, paying for childcare subsidies, transportation, food subsidies, continuing education or formal education for staff, whatever assistance programs make sense that would help both recruit, attract, and also retain people. So those grants were already released. Because of Helene, we have extended the deadline for those grants until the end of the month. So hear that. We're announcing, I think it's coming out tomorrow, that the grant timeline to respond will be extended till the end of the month. We'll also set aside money for a future grant opportunity for the West. We know some communities in the West, the end of the month's not going to cut it either. And I want folks in the West to know that we haven't forgotten. Okay, next slide, please. We're also releasing a grant today for employer of record. Same thing, recruitment and retention grants, because employer of record's different. Provider agency has a certain construct, has a certain infrastructure. Employer of record is often a parent, right? It's a parent working with a family member, but same thing. How can they creatively use this grant to recruit and retain employees for whatever it is that would help the employee stay? So again, that was released today. And that will close mid-December. So the goal of both of these grants is to try out different recruitment and retention strategies to see what works, and then to find an ongoing source of funding to continue these kind of programs. All right, next slide, please. So moving away from direct support professionals, another important part of the workforce are our peers. We have launched our new Certified Peer Support Specialist website. It's a one-stop shop for getting your statewide certification for understanding the quals to be a peer. There's resources there for providers because we want more providers to hire peers. We also released scholarships so peers can go and get their certification for free. And you'll see information on that website too for specializations. So we have trainings for folks in the justice system, for older adults. And as I mentioned, we're working on peer certification for IDD as well. So you can join the advisory committee, you can get on a listserv, but our support of peer specialists, we just want to keep making it simple, making sure that your training is high quality, making sure there's a pipeline for you to actually get employed. You're treated with respect when you are employed. We're helping providers employ people. So there's a lot of peer work underway, and there will just be more because we really believe in peers. Right, next slide, please. So in our strategic plan measure set, we will be measuring the number of scholarships we give for DSP training programs, the peer support specialist scholarships we give out, the direct support professional turnover compared to what it was historically. I don't know if you know, we measure turnover all the time. Believe it or not, our turnover is lower than many other states in our region. We're actually lower than a national average for turnover, but we still want it to get better and better. And we actually want our peer support specialists to be employed as peer support specialists. Less than 40% of our certified peers are employed as peers. And there are a variety of reasons. Some people just wanted to get the training, but other people just don't feel like they can find a job or be respected in that job. So we want to measure peer support specialists who are actually employed because we think they're valuable in recovery and in our workforce. All right, next slide. All right. Priority area 5 is strengthening the crisis system. We want to make sure people know how to find crisis care. We want to make sure that our mobile response is timely. And we want to increase the use of our community facility-based crisis because it is a much better alternative to emergency rooms in many cases. Next slide, please. Lots of initiatives here, lots and a lot. But on the left-hand side, those kind of all go together, which is investing in the right number of facility-based crisis, behavioral health urgent cares, mobile crisis teams, mobile crisis MORS teams. Those are mobile crisis teams specifically for adolescents, and finding a way to financially sustain it all. Okay, it is a safety net program. Lots of folks who come are other insured or uninsured. And we need to make sure that it's funded well, this alternative crisis system. If you look in the middle column, one of the things we want to do is to make sure that people actually understand this alternative crisis system. We're launching a campaign called Crisis to Care, although we may change it a safe place to go. We've been working a lot with consumers in the field about what's most important to them about a crisis system. And the thing that seems to be resonating is a safe place to go where they'll be taken care of and not judged and safe, which is very, very, very compelling, right? So we want to make sure we get the right message. But we want to make sure in all communities that people actually know to call 988 and what happens when they call 988. And that 988 can deploy mobile crisis. And that mobile crisis will get there in 30 minutes. And if you have to go to a crisis center because you're not well or your kid's not well, you can go to an urgent care, you can go to facility-based crisis. It means we need a predictable, well-funded system that we can advertise and that people know to use. We will continue to expand 988. We'll continue to expand our bed registry. Right now, most community psychiatric and state psychiatric hospitals are on SCAN, so we know where beds are at any one time in the state. We also have the crisis facilities, and now we'll be onboarding our PRTFs. So again, this is our big old bed board where people can also look for availability, but can make referrals in the system. We launched the Peer Warm Line. Hopefully folks know. 855 NC Peers, or Peers NC, said that backwards. And we will continue to expand that because it's awesome. Over 8,000 people a month call. We'll be expanding our suicide interventions here at the division. And that means hiring a suicide specific coordinator and making sure we're doing things like post-suicide attempt outreach and follow-up programs. As part of that whole crisis continuum, we'll also continue to fund more co-responder models, which means social workers or clinicians riding along with EMTs and law enforcement. I'll mention the non-law enforcement transportation pilot in a moment. We're also working with North Carolina hospitals and with LMEs and our Medicaid system on the idea that people do go to the emergency room. And if they do, what is a better environment for them? So we're looking at something called an empath unit or a psychiatric ED. So we're exploring those opportunities that other states are using. Empath units are very popular right now in other states. And we're working with our hospitals to see if there are alternative psychiatric hospital ED settings that we could potentially pilot here in North Carolina. One of our stretch goals is really to revamp our involuntary commitment, not just the rules, but the process and the understanding. We don't think people always need to be IVC'd. People should have choice. Parents should have choice. And we need to make it clearer and make sure that there is dignity and respect in that process when someone is in crisis and they may need mental health supports. Where do they go and what the process is like? We also, in all of this crisis service redesign, we need to make sure that we have a system that really supports people with intellectual and developmental disabilities. I'm not saying it has to be a separate system. I'm saying when people call 988, if they go to a behavioral health urgent care, if they go to a facility-based crisis, if there's a co-responder ride along, do they know how to meet the needs of people with intellectual and developmental disabilities? To our mobile crisis teams, do they need an IDD specialist on the team? Probably so. We need to make sure that we're able to help anyone in crisis, and we never have a situation where someone's like, whoa, that person has IDD, I don't know what to do. We need a comprehensive crisis system. Next slide. I'm gonna unpack a couple of these. I think hopefully you know about the crisis system we've been working on this past year, which is someone to contact, so 988 pretty much, or the peer warm line. Someone to respond, which again is typically mobile crisis. We don't have enough, we don't have quick enough response, right? And then a safe place to go. We don't always have enough urgent cares, we don't have enough facility-based crisis, so we have been seeding more of these across the state. We're trying to be judicious using data to determine where these facilities need to be. We're repurposing other buildings or expanding buildings, right? And we're trying to make sure that then we have a plan for continuing to fund these in communities. They're very important. Okay. Next slide, please. This is where we have placed new crisis facilities across the state this year. We have added, with funding from the General Assembly, 44 new child beds and 64 new adult beds, 9 more behavioral health urgent cares, 1 new co-responder team. There's been a lot of new crisis infrastructure built in partnership with LMEs and providers this year, a lot. Now we want to make sure it is well known, well advertised. These are well funded, and there's continuity of funding in this system. Next slide. I mentioned in passing the non-law enforcement transportation. We should be releasing, I hope, by the end of the month, I hope, an RFP for a non-law enforcement transportation pilot. We want people who are in an ED who need to go to a hospital and have to be transported to not be transported in the back of a police car. We want them to go in non-law enforcement transportation. So we're very excited about this opportunity to try safe, therapeutic ways where folks aren't in handcuffs when they need to go to a psychiatric hospital. Next slide. Measures. We're going to continue to measure calls to the 988 hotline. We're going to continue to measure people using a Medicaid or state-funded crisis visit. We're going to continue to measure the number of individuals served in a facility-based crisis or in urgent care. We're going to continue to measure the number of people in an emergency room for a psychiatric issue. And we're absolutely going to continue to measure children in the DSS system who are at an emergency department or in DSS office and waiting for care, right? They're waiting in an emergency room for far too long, or waiting in a DSS office for far too long. So you can see right now that this measure that we're showing you is the number of people served in either a facility-based crisis or in urgent care. Again, fairly static, and this pretty much just corresponds to the number of beds we have. Just by virtue of upping the beds and looking at the sustainability of the funding model, we want this to go up. Do we want people to be in crisis? Of course not. But if they are, we would like them to use a trauma-informed behavioral health crisis system rather than calling 911, being transported in a law enforcement vehicle and waiting in an emergency room and getting IVC'd. We need an alternative trauma-informed system. All right, next slide, please. Priority 6, down to the last 2 priorities. I'm looking at my times. Okay. You know that we've been engaged in expanding services for individuals in the justice system. So we want to make sure that we increase engagement in deflection and diversion programs. So this is people that could go to prison or jail, but let's not. Let's get them into treatment instead, which is where they need to be. For folks who are incarcerated, let's help make sure that their entry back into the community is successful because they're getting transitional housing, they're getting mental health substance use wraparound supports, they're getting Medicaid for opioid use disorders, they're getting help with job and employment supports. So let's make sure we're doing reentry well. Let's make sure that the programs we have for youth are adequate and understandable. They're too spotty, they're not consistent across the state. And so we've been working with our partners in juvenile justice and DSS to develop a more comprehensive set of community supports for children in the juvenile justice system. So they're both diverted and they have reentry services, but they also have community services. And then we want more capacity restoration. Capacity restoration, again, these are folks who are considered by the courts unable because of their mental health issue to go to court to stand trial. So they wait. They wait to go to a state facility for treatment, so then they can go to court. And the wait is incredibly long, and it gums up all of our state facility beds, right? Or gums is probably a better word. It fills them, right? And so we're using them for the capacity restoration instead. So this program allows for capacity restoration to happen at a detention center or in the community rather than a state facility. Gets folks through the process, gets them the treatment they desperately need, allows them to go to court and then go back into the community for treatment. Next slide, please. So I mentioned some of these, but we are continuing to expand, and I think I have a map, our diversion programs. TASK is a very specific statewide program that all law enforcement, probation, and parole actually know. And and many of our behavioral health or mental health and substance use providers actually are task providers as well. This is care management treatment to help people transition back in the community. So we want to well fund and strengthen that program because it is across the state, and all probation, parole, jails, prisons actually know about it. So we want to strengthen it and make sure it's well funded. We want to train our partners in the justice system, and that's everyone from law enforcement response, it's judges, it's court personnel, so they understand our service delivery system and they know the opportunities to divert people into treatment and they know that it works. So a lot of education. We want to make it easy for them to recommend treatment for someone rather than prison. We want to invest in actual treatment programming in the community for people with justice or forensic issues. It's a specialization. Understanding the trauma and all the experience you have when you're involved in the justice system, that takes unique skills and services. So one of the services we're trying to support are FACT teams. They're ACT teams, so the comprehensive wraparound services for people with forensic experience. So we're standing those up across the state as well. I mentioned strengthening our juvenile justice teams and service arrays across the state. We have them across the state. They're just different in all communities. They're not as well funded, and all communities don't know how to use them and what they're for. We'll continue to fund more transitional housing and employment for people leaving carceral settings. We'll continue our investments. We have right now, you may not know, we have community re-entry programs for people who are incarcerated and who have intellectual and developmental disabilities and traumatic brain injury. So we're actually training Department of Adult Correction staff on intellectual and developmental disabilities and traumatic brain injury, and we'll be expanding those services. So we're making sure we're addressing the needs of those folks involved in the justice system as well. So lots of interventions already happening in the state. If you look on the next slide. So this is, again, I mentioned what we're trying to build, and we have a lot of component parts, but we're trying to get better at telling you the story of what we're doing and making sure we're funding those spaces consistently, which is educating the justice system, making sure diversion and reentry is largely about care management, helping people to navigate and make sure they have the services and supports they need, like housing and employment supports, and then making sure they have adequate, informed, well-trained treatment, everything from peers to mental health and substance use teams that understand forensic issues. Next slide, please. These are all the places right now where we have deflection, diversion, and reentry programs. So there's a lot. Many here serve other counties, but we have an RFP out right now. We just extended it in light of Helene until the end of the month to build more diversion and reentry programs and housing and employment programs across the state, right? So you see where there's a concentration of them. There's lots of spaces here that don't have programs. So we've released an RFP to develop more of those supports right now. Next slide. So our strategic plan measures are measuring people who are served by a deflection and diversion program, people who are served by a reentry program, youth who are served by a deflection, diversion, treatment, or reentry program. And then individuals who are receiving community or detention-based capacity restoration and not having to wait for a state bed. So we're measuring that now. That's the measure you see right now. And again, we're trying to build 3 regional capacity restoration programs. One is built, and we expect the next 2 to come online in the next 2 months, which will be exciting. And we know that when that first program opened up in Mecklenburg, it filled up immediately. So we know this is excellent. We're getting more people into treatment that they desperately need. This is very exciting. All right, next slide. This is our last area, actually. This is one that is very near and dear to the heart of our division. This represents often the people with the most complex needs that we support here at the division. So one of the things we want to work on is increasing our early detection and recovery services. And I'll explain what those are because we have first episode psychosis programs. They're exactly what they sound like. A person's first entry into the system where they had a very serious, maybe psychiatric admission, a psychotic episode, if you will. They're 17, they don't know what's going on. And that's a wonderful time to engage that person, educate them and the family, and move them into a life of recovery, not a life of treatment per se. Want to grow recovery support, so things like peer services and recovery community organizations. And then our children. Children with the most complex needs are in our residential facilities typically, and they need a lot of work. So let me tell you what we're going to do. Next slide. So I mentioned these already. First episode psychosis. One thing I want to mention, because it's not in the next slide. We're going to talk about residential redesign, peer living rooms, first episode psychosis, but clubhouses. For those of you that I'm a huge clubhouse fan. And we've been working with the national clubhouse folks on what are the best ways to support our current clubhouses and even build more. Clubhouses are wonderful programs where people engage with peers and they have employment supports and they engage with the community. And we think they need some funding, love, and attention. So we'll be doing that with our funding this year. All right, next slide. So recovery community organizations, they are what they sound like. We have 15 of these right now. They're peer centers. They're people in recovery supporting other people in recovery. We have 15 of them. You may not know that. And we're going to continue to use our block grant funds to build more. We believe in the power of peers, and I think it's something that communities just need to have. You should have a recovery center or a peer center. You just should. It should be part of the recovery continuum in North Carolina. Next slide highlights some of our peer centers that we fund right now, like Green Tree and No Wrong Door. We want to fund more of them. Again, I think a recovery center or a peer center is just a vital part of any community. It's a place where you can go and talk to someone who knows what it's been like for you, can help you navigate this system that makes no sense sometimes. But we need to continue to fund and build more of these in North Carolina. Next slide, please. Our first episode psychosis program. I'm actually going to use 4 or 5 slides to talk about them because people don't know about them. We currently have 6 sites. 2 of our sites were heavily impacted by Helene, and so we're working with the UNC team and our team on supporting those 2 sites, but we have 6 sites across the state. Next slide, please. I want to put some of these in here because it's really important that you think about the people served by our first episode psychosis programs, and this is huge. This is about prevention, y'all. The majority of people, more than 60% of people served by first episode psychosis programs are under the age of 21. These are very young people, like I said, who've had their first psychotic break, who are hospitalized. They don't know what's going on. Their parents don't know what's going on. And there are some fortunate people that get connected to these first episode psychosis programs. Next slide. Look at the results of people in the first episode psychosis program. The yellow is they're not working or they're not in school. The dark blue, the green, and the light blue are working in school, working in school. Over 5 years, look at the trend. These folks are not governed by their illness for the rest of their lives. They understand it, they get treatment, they get connection, their family gets education, and they go on to live and work independently. And that's what we want. So these first episode psychosis programs are really important. Next slide. People in the first episode psychosis programs also utilize much, much fewer crisis mental health services. Again, a life of recovery. Next slide, please. The last thing I'll talk about then is, so we talked about peer centers, recovery centers, first episode psychosis. Let's talk about our kids for a minute. I could talk a lot about this, but I'll try to be brief. We really need to strengthen our residential continuum for children here in North Carolina. Here are some of the problems. We're over-reliant on residential treatment. We don't have specialized residential treatment. So children who have intellectual and developmental disabilities, who are younger, who have significant trauma, who may have manifest by physically being aggressive or acting out. it's very challenging to find treatment settings for these children, and they end up languishing, or they end up being potentially sent out of state. And within our own treatment settings, as we've come to visit them and get to know them all, they're trying their best, don't get me wrong, but there's not a lot of uniformity or quality in the trauma-informed treatment models and methods that they're using. So we know that we want to tackle all three of these particular issues. Next slide, please. So we want to have a system. Let me say this because it's not on the slide. This is only a 5-year plan. But let's say in 10 years, how about a system where we do not have residential treatment anymore? How about that? You know, there are states that don't have residential treatment for kids. It's true. But in the meantime, we've got 300 odd children in residential facilities. Let's make sure they have the best experience they possibly can, okay? So we are committed to a system that is safe, that is trauma-informed, that has high-quality treatment. The kids have the right level of care that they need, meaning if a child can be served in a least restrictive community setting with wraparound services, that's what they should have, period. If they do need a residential level of care because they meet that level of care, okay. But when they're there, it's highly therapeutic, it's brief, and we are planning for community-based reentry with wraparound care during the whole visit. All right. And we have enough in-state specialized capacity that pays appropriately for children with unique and special needs. Again, young kids with IDD and mental health issues, children who face significant trauma. Let's make sure that we have adequate treatment for them. Children with eating disorders, right? Let's make sure we have that adequate treatment. Next slide. One of the first things we're doing in this space, you're going to see an announcement any day now, are things called our environment of care investments. As you recall, when the General Assembly made that $835 million investment, 80 million of it went for children's services. We've been working with our partners at DSS, DCFW, and Medicaid to revamp the continuum of services for children. And that's everything from respite to community-based mental health services to treatment foster care to parent partner programs to kinship care. We're at the deep end of the pool with this residential care. So we're trying to improve that continuum of care while working with our partners to make sure that we've got those community preventative wraparound services in place. Because again, we'd like to get rid of residential care altogether, okay? But one of our very first investments are something called our environment of care investments. We're funding 25 providers. This is a competitively bidded project. We are providers were allowed to pick from different trauma-informed interventions or practices or environmental or therapeutic things they wanted to do in their spaces. That could be outdoor recreational space, a sensory room, new equipment for kids, new bedrooms for kids, new paint, just things that made the environment more therapeutic. And so after going through all the applications and working with all of the agencies and the LME MCOs, we are funding 25 unique projects. So those will be announced. And those providers who get those awards will also agree to work with us on quality treatment, redesign, and supports within their programs. Right, next slide, please. In this space, again, these are individuals with the most complex of needs. We're going to measure the number of people served either in a respite, a peer living room, a recovery center, the number of people in our first episode psychosis programs. It's been pretty stagnant. We need more of that. We need the number of individuals receiving services in a clubhouse. It continues to go down. But again, are we really utilizing clubhouses in the ways we could be? Are we funding them the ways we could be? Probably not. We want to continue to decrease the number of children served in out-of-state facilities. A lot of children are served in border states like Tennessee and South Carolina because they're actually very close to home, okay? I'm talking about really out of state, not right across the county line where you can actually visit your family. We're trying to make sure that we're keeping kids in state, keeping kids close to home. They're always connected to their community. And then lastly, we need to get that average length of stay down for kids in residential facilities. So again, if we must have residential treatment, it should be highly therapeutic, it should be safe, it should be warm, it should be brief, and it should be connected to the community the entire time. All right, next slide, please. So what's next? That was a mouthful, y'all. That was 7 big areas. Lots of exciting things we're working on. But I want you to think about how many different communities we work with. We've got teams that work on all of this here, and they work with you. All of these priorities are important to us. All of these populations of people are important to us. And so we wanted to make sure that we did justice to each one. So it's a lot. I understand that it's a lot, but that's our commitment to you to say, this whole organization, this is what we're focused on, these things. They align really well with the department's priorities. Of course they do. I hope that you see that, right? They align with our sister divisions because we'll do everything in partnership with them. And it's a lot, but it's our commitment to say, look, we sussed out the whole continuum of what we provide for the people we support, and this is what we need to work on now. So what's next? Later this month, we'll release the strategic plan dashboard. We'll remind you of the interventions and the measures. We are going to update the plan annually because we're going to make progress on this. So we're going to have to refresh our goals and refresh our measures as we continue to make progress in these areas. And we'll provide regular updates at side by side. Next slide, please. I think we're up to the Q&A. So because I've been talking a lot, and I think I said Renee is off today, and Sarah and Ginger are both at other engagements where they would have co-presented with me. So I did my best to represent the whole team today. But Elliot, do we have any questions? We did take the whole time.
Yeah, yes, we do. And I will direct it at other team members so you can take a break, drink some water, and of course you can weigh in as necessary. So Tina, this first question is for you. So for the employee retention grant, can you clarify what population the direct support professional staff can support? Is it just individuals with intellectual developmental disabilities?
Yes. So for the DSP recruitment and retention grants that we currently have available, those are to support DSPs who are staff that are working with individuals with intellectual and developmental disabilities.
Thank you. And I think also you flagged in your response that it includes co-occurring individuals as well.
Yes, of course. Any person who is duly diagnosed would also have an IDD diagnosis, and therefore the staff working with them would be eligible as a DSP.
Thank you, Tina.
Sure.
Lisa, next question is for you. Could you please speak to what the department is doing around the involuntary commitment process?
Hi, yes, sorry about that. So we are looking at with, like Kelly mentioned earlier, our non-law enforcement emergency transportation, which will aim to decrease the number of involuntary commitments that are used for transportation only. And we are also going to be looking at the involuntary commitment legislation as we continuously do. We want to ensure that we are making improvements that work into the community.
There's a lot to do in that space, and we will engage our advisory committee when we really do a deep dive on IVC. It hasn't been updated in a really long time, and I think there's a lot there in terms of everything from just making sure people know their rights in the process and know what they can expect, what families know, so they can advocate and make sure the process works well. That we work with community to train them on the process, because a lot of people just pick it up or pick up a rumor or an antiquated process. Our team's actually working right now at making the project, making the IVC process online, so we can actually track it better and see what's actually happening in the flow of IVC. I think that's really important. But I don't think there's anything getting around that, even if we get everybody attuned to the actual process and families knowing their rights, that we don't have to make it better. We do. We need to make it better so we have less involuntary commitments.
Unfortunately, we are at time. So Lisa and Kelly, thank you both so much, and Tina. But Dina, I'm going to turn it over to you.
Okay, thank you, Elliot. If we did not get an opportunity to answer your question during the webinar, questions and feedback are welcome at bhidd.helpcenter@dhhs.nc.gov. The recording and presentation slides for today's event will be posted on our Community Engagement and Training webpage. The links are included in the chat box. There will be a brief survey following today's webinar, and we would appreciate your time completing it. Our next side-by-side webinar is scheduled for Monday, December 2nd from 2 to 3 o'clock p.m., and we look forward to seeing you then. This concludes our webinar for today. Thank you for attending.